Hello everyone, my name is Gifty Manmeetkar and I'm a current student at United States University. Today I'm presenting the case of JD, who is a 36 years old Hispanic female, presented to my clinic complaining of severe palpitations, uncontrollable anxiety, insomnia, and an unintended weight loss of 13 pounds over the last 2 months. So why this case was meaningful to me? So this case was exceptionally meaningful and challenging to me because the patient had a documented history of generalized anxiety disorder. She arrived fully convinced that her physical symptoms were entirely a physiological failure on her part to manage her stress as a mother and a teacher. This encounter served as a powerful reminder of how easily organic endocrine pathologies can hide behind or be dismissed as psychiatric diagnosis, highlighting the critical need for comprehensive, different diagnostic sorting and provider diagnostic humility. So, presentation of the case, I have the subjective summary here. So, JD is a basic kindergarten teacher and mother of two who reports a 2-month history of a racing heartbeat, extreme heat intolerance, hyperdefecation, and persistent insomnia. Her past medical history is notable only for mild anxiety, which she preferred to manage without medication. Her family history is significant for an unnamed thyroid condition in her maternal aunt. Objective summary for my case. On physical examination, her vital signs revealed a resting heart rate of 116 beats per minute and a blood pressure of 136/80. She was visibly having some tremors and she was diaphoretic. The most pertinent physical finding was a diffusely enlarged symmetry non-tender thyroid gland, which was roughly double its expected size. Neurologically, she demonstrated a fine tremor in her hands and bilateral patella hyperreflexia. Assessment and critical thinking, differential and diagnostic narrowing. Initially, given her psychosocial stress and history, an acute panic or generalized anxiety disorder exhibition was high on the differential. However, her profound weight loss despite an increased appetite paired with the objective finding of a large goiter and a hyperreflexia structurally ruled out as isolated physiological issue. I also considered postpartum thyroiditis, but her last delivery was like 18 months ago, placing her outside the typical transient timeline for that condition. Final diagnosis for the patient. So, based on the presentation of systemic thyrotoxicosis accompanied by a diffuse smooth goiter and classic oculomotor lid lag, the final presumptive primary diagnosis is grave disease. My plan and evidence application action. So the plan is like I'm gonna validate this, like I ordered some blood work for the patient. I'm gonna check like a TSH, T for free, T4 free along with T3 free, and some of the thyroid antibodies too, along with the baseline CBC and the liver panel. To protect her cardiovascular system from a hyperhidrogenic strain, I prescribed like a 20 milligram of propranolol, 20 milligram of propranolol 3 times a daily, following the evidence-based American Thyroid Association guidelines. Once the lab confirm the autoimmune etiology and verify healthy baseline hepatic and bone marrow function, we will initiate the methimazole therapy. Alternatives. So alternative options like radioactive iodine therapy or a total thyroidectomy were discussed briefly as the future definite pathways, but the patient strongly preferred to explore primary medical management with anti-thyroid drugs first to avoid permanent structural ablation while her children are so young. Holistic approach and caring science, collaboration, and cultural consideration. A holistic approach was vital for JD. As a Hispanic woman, she expressed a deep-seated culture fear of being perceived as weak and unable to handle her family duties, which had caused her to internalize her severe anxiety and delay seeking care. I collaborated closely with her and her husband who attended the visit by validating their exhausting daily schedule and framing this illness not as the emotional deficit but as a manageable medical condition. We collectively built a stress reduction plan that included like a temporary teaching, modifications, and family child care support based on the Gene Watson science application theory. developing and sustaining a helping, trusting, authentic, caring relationship instead of rushing through her rapid speech and anxious presentation. I sit down at eye level, maintain steady contact, and actively listen to her fears by validating her lived experience and expectedly reassuring her that her racing heart and insomnia were real physical expressions of the thyroid hormone imbalance rather than the failure of her mental health. I was able to relieve an immense emotional burden. This established a deep baseline of clinical trust, enabling her to confidently understand her critical medication safety parameters and actively participate in her own healing journey. Thank you.